move on with the programme, we'll have a brief presentation from Dimitrios Pousios, Deputy Adult Cardiac Surgery Lead from Southampton. He's presenting on behalf of Uday and the team. Uday was unable to make it today, but just to give us an update on where we are with the SCTS Adult Cardiac Surgery database and the great initiative that we can, improvements we can get out of it. Dimitrios.
So thank you very much, Noreen. I'm presenting this on behalf of Uday Trivedi because that's essentially his baby, which we are all excited to see taking the first steps, really. So just to give you a little bit of, reminder from the past, this started really from the concern or the frustration, perhaps, that the data that we are submitting as units to NICOR from NACSA is not really ours. It's used mostly exclusively for governance reasons. There have been some production of that, but it's not really easy to use. You can see your benchmarking across the country, across different units, and frankly, the scientific sort of output is very, very small for such a big database. So what started as a first idea was a benchmarking dashboard that Uday started with an offer initially from Dendrite to host a national dashboard on behalf of the SCTS free of charge. That would be free of charge for all cardiac centers, and it would not have to do anything with the actual database software that's being used. You did not have to use Dendrite. Every unit can have their own. So this started almost a year and a half ago, I think, with a pilot study with a few centers, I think pretty much a handful of them. And the pilot dashboard was presented initially at BORS and then to the SCTS executive, and actually a presentation has taken place at the annual meeting as well. This was satisfactory and the agreement was to proceed. Just to show a little bit, although the slide is a bit minimal there, you can see, for instance, this is actually Royal Sussex Hospital, Brighton, Uday's unit, with blue compared to the rest of the country, which is the yellow. So you can benchmark on cabbages, which I have here, waiting times, outcomes, and also all what we call softer but quite more up and coming morbidity measures, not just mortality, because we all as a society have moved a little bit away from that. And similar for AVR, including blood clots and comparison with the rest of the country. So you know pretty much how you're performing, not just by the sheer sort of league table of outcome of mortality, but of everything else that includes the care of the patient from the beginning, from how much time it takes to go for cabbage until the end of the patient's involvement with us and handing back to society. So the next steps was to team up with University Hospital Bristol and Western, and basically that would act as a joint data controller with the SCTS, and Dendrite would act as a data processor. So the plan was to have a joint data sharing agreement between the SCTS, Bristol as the controller, Dendrite as a processor, and the unit to collect anonymized data. Effectively, that's the NACSA, the NICOR dataset. So it doesn't really change. It's pretty much the same as the one that normally every unit is supposed to submit every quarter. And that would work in sort of a little bit this algorithm. So the data that's going to NACSA, just a basically copy to or CC button to through Dendrite to the dashboard, and then the unit could deduce from the dashboard any information they would like to have, and at the same time on the side, the processed data would be available for any research audit project that would go through a data access committee that would be appointed by the society and administered by the society, not from the Dendrite or Bristol alone. So pretty much everyone that has a question doesn't have to pay the few £1,000s that I'm sure people have faced when they ask something from NICOR. So where are we now with this? Quite exciting. We have a registry of cardiac surgery. We called it sort of affectionately ROCAS for lack of any other name. So that's now active. All approvals were in place between Bristol, Dendrite, and society. A letter that is a cover letter, an introductory letter, an explanatory letter has gone to all the audit leads, the cardiac audit leads of the units in the UK. Scotland is a little bit different because they have their own program, but they are actually quite interested, and there's discussions whether they could submit their data on that when it becomes live. And the database registry can start with 12 units, and eventually more would hopefully join. So you need a minimum of 12 units to start it being functional. And of course, the quality of the benchmarking, the quality of the research output would increase and would improve with more units. We do around 30,000 cases a year, the whole units. So 12 units, we give around 10,000. So that's quite a nice number, but it would be much better to have 3 times more of that. So this is the letter that was sent. I'm sure that people that have seen it perhaps, or the audit leads as well at the same time, have seen it. And this is the first page of the data sharing agreement, which is again, not a very complex document. It has to be discussed obviously with the information governors, directors, managers in your trust, and then signed by the trust, to be signed by SCTS and by Bristol as the data controller. That went on into spring. Some units responded. There was also some discussion about the patient opt-out data issue, whether this is exempt as it's applicable to the NICOR submitted data. There were discussions between SCTS and the NHS England, and the outcome is that a revised letters will go to the units that will clarify the following: that only anonymized data with all individual identifiers will be submitted, and that the exemption of the opt-out that applies to NACSA, to NICOR, does not apply to this database. So there is a little bit of extra work for the data manager of the unit that they have to apply. Apart from anonymizing, they would have to check the register of opt-out patients and then remove those patients out of the database before it's submitted to the registry. So how many have signed so far? 12. And the 13 is about to pipeline quite soon, and I can tell for sure because that's my unit. We lost our information governance manager, so there will be 13 units probably by the end of the next weeks or so. They already have signed the agreement, so pretty much that can turn the database, the registry, as a functional system. These units will receive the updated letter, so they will have to re-sign it again, I'm afraid, to conform with the new agreement. The other units will receive again another letter, which is the updated one. They haven't signed the first one, so quite easy to just put the first signature in there along with all the details they want to ask. Does it finish here? There are further steps to be considered. There is a lot of discussion happening behind the scene because this is still a work in progress. So SOPs or data manual is potential to be introduced to help the data managers of the unit and the audit leads, obviously, how to work on the storage and the processing, but pretty much the infrastructure is in place because this is the NACSA requirement that everybody does now for the last 12, 13 years. Every quarter. Dendrite would be very happy, I guess, to create a workshop for data managers, FAQ, webinar. This is all possible to be done to explain and answer questions. And obviously, I'm sure Uday and the society and myself will be very happy to receive any questions and answer. And this thing, as it grows, it will create more questions, more definitions to be done. But we look forward to that. The value. The benchmarking we mentioned, national audits, national research, publication for individual members, units, the society, pretty much what the Americans have with the STS database, which is, I'm going to have to say this is the best in the world. And hopefully in the future, if we progress to non-anonymized database, with longer, we can connect with HES data, long-term outcomes, and all the questions that very well sort of Narayan said about the mitral study, which costs 6,000 to ask NICOR for what it's actually filter, tick, 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 tick on Excel, even with my non-very good Excel skills. It takes around 5 seconds to do. It will be available to everyone. But the most important, that I'm sure Uday wanted to press, and I'm happy and I'm humbled to press, is please join the registry. It's only a signature. And then the data manager will just CC that one as well. That's pretty much it. I'd like to catch up for the lunch.
Any questions for Dimitrios regarding the database in the room? Got one question online. Adrian Marchbank, why does the opt-out apply if the data is anonymized?
Probably, I'm not sure where I can answer. Probably.
I'll try to just to reiterate the importance of why this database is important to us. And we're starting with adult cardiac surgery, but there are plans to move on to congenital and thoracic surgery. For want of using Boris Johnson's phrase, it's about us taking back control of the data. You do the operations, you submit the data, but yet when we want to try and use that data to improve clinical outcomes, it is a struggle. This database will be essentially the same as what you submit. As Dimitrios said, there are some slight tweaks that your database managers will need to do, but from what we've been told with the opt-out question, it's very few patients and a system's already in place about how those lines get extracted. To answer Adrian's question, I think if patients don't want their data to be used in audit or research, they have the option to do that, whether it's anonymized or not anonymized. So I believe that's the answer to that question. But just the importance of what this will allow us as a specialty and as a community to do about driving clinical outcomes forward is crucial. And thank you to the 12, 13, and I know of another one, 14 units that agreed to it. But the data will be more powerful with more units, 10,000 already. If we can get to 20,000, 30,000, 25,000 patients, it will give us a phenomenal output to allow us to guide our clinical practice moving forward. And I can't stress how important I think this project is for us moving forward. I appreciate it's about going through information governance and getting it processed through your own units, which sometimes is easier said than done. But if everyone can understand the importance to the society for national driven audit projects, as well as nationally driven research projects, but also to use individuals, you all carry out audit projects on data you have locally. This will give you access to information and data that's collected nationally to run an audit project that you want to look at. On top of that is the benchmarking and the outcome monitoring, and allow us to understand where we are to simply improve patient outcomes. So I'd really encourage you to go back to units, ask, has your units, we've chosen not to name and shame today, but to ask, has your units sign the data sharing agreement, and if they could, because this is a powerful tool for all of you to take moving forward.
Hi, it is Leon Nicolau from Leicester. When would I send me actually the request to participate? I hadn't realized, I'm the clinical audit lead, by the way. I didn't realize actually I have to go to the higher management to have authorization, because this is what I gathered from your presentation. I responded back as a clinical audit lead, saying that's fine. But that was just an email. But from your presentation, I gather actually I have to have a documents, countersigned or endorsed by the higher management. Am I wrong?
I think that you can.
You don't need to have it countersigned by management, but you'll need the data governance and the clinical audit team to be involved in the process, because ultimately they'll be doing that. The signature is on your behalf, the University of Bristol and the SCTS are the three signatures to that document. So.
And every unit as well has their own sort of channels of communication, but the signatory from the trust is the clinical audit lead, the cardiac audit lead.
Hi, Charles from Bristol. Thank you. Great presentation. More clarity, I guess, for the members and BORS. Can you just clarify for them also whether this is going to be a prospective project or whether retrospective data from the databases will be added to add power to the value of it?
It was retrospective. But at the moment, I think the most important thing is to get it going forward and get people to start pressing a button, because different units have different, perhaps, retrospective databases or collection. In an ideal world, it would be very nice to have all these last 10 years, which the data is there because it has already been submitted to NACSA. So I would very much encourage people to sort of think about that. But at the moment, I think we just want to go live first with the prospective data, so we start collecting, and then the plan is to get the retrospective data later on, because it's the same. It's just the get button plus the opt-out.
I echo that. The legacy data will be phenomenally important. It will give us the answers to some of the questions we want now. So as Dimitrios said, it's a process, and once we get engagement of all the units, we can make those changes and identify those and analyze that data to change how we deliver clinical practice.
And this is for the future generations. I'm 53, I have another 12 years perhaps. this database will be probably in 10 years will be something like 200,000. That's going to be a strong database, even without their perspective. So I think that the future generations will benefit from that. And I think I can see Uday's vision on legacy with that.
To continue on just the questions, first, thank you, Dimitrios, fantastic projects, initiatives that taken forward.